So can I ask Teemu Karjalainen to come and tell us about outcome measures for assessing the effectiveness of treatments?
Good afternoon, everybody. So my name is Teemu Karjalainen. I'm coming from Finland, and we have a research group that is looking at how different interventions work, and Dupuytren being among one of those. So we're basically doing trials, we are doing Cochrane reviews, and we are doing some outcome research. So I have no relevant conflict of interest regarding this one. So on this talk, I'm not talking about the outcomes of our trials. I'm covering that tomorrow in tomorrow's speak. So we're using data in this outcome paper from a pragmatic 6-center randomized control trial, which is comparing long-term effectiveness of surgery for primary and recurrence and needle fasciotomy followed by surgery in non-responsive cases and collagenous injection followed by surgery in non-responsive cases. So what is important, maybe the exclusion criteria, so we didn't take any recurrent contractures in this one, and the contracture angle, the sum of treated finger, needed to be under 135, not over, sorry about that. So our primary endpoint was success for the effectiveness, and then for the progression, but I'm having the wrong talk now, sorry. It looks, this is tomorrow's talk, so can we change the slides for the other talk I sent?
Give today's talk tomorrow.
We haven't lost anything yet because we have the same data.
Do you want to see if they can change, or are you happy to continue?
I can continue with this one also. Okay, so let's continue with this one. So basically, this is the analysis of our trial. So what we did, we randomized people to these three treatment strategies. And on this analysis or this talk, I'm going to cover the effectiveness and progression. And the effectiveness, the primary outcome was success, and I will tell you tomorrow why it was. So the success was that patient reached accepted symptom state. So we asked whether you are happy with your current state of your hand and not in need of further procedures. And the patient had to have at least 50% contracture release. And for progression, instead of looking exceeding some cutoff, we looked at the increase in the contracture between 3 months from treatment and 2 years from treatment. And then we look at the retreatments. Secondary outcomes, we had a lot of those. We randomized 302 patients, and the follow-up was at 3 months, 97%, and at 2 years, we had 94% follow-up rate. So let's look at the effectiveness results. Success at 3 months on participant level was similar between all the treatments, no difference in the rate of success. However, at 2 years, surgery remained at about 80%, whereas needle had declined to around 50%, and the collagenous was somewhere between. So there was a 30% risk difference between surgery and needle, and about 17 risk difference between needle and collagenous at 2 years. And this is the success. So what about the secondary outcomes? They were basically similar. So between surgery and needle, we found difference in most of the outcomes, whereas between needle and collagenous, we didn't find any significant differences, so they are smaller. So what about progression? So we can think that surgery is a bit more aggressive, there's more trauma, so it could actually cause the disease to extend to or progress in the adjacent fingers. And then on the other hand, when we are moving the tissue, we could have a lesser progression. So what happens? So in the treated fingers, what we are seeing is that the primary results were exactly similar, but then at 2 years surgery, the results are maintained, whereas it just gets a bit worse. About 10 degrees difference between surgery and needle, and about 6 decrease difference between surgery and collagenous. So what about the untreated fingers, the extension of the disease? So no difference at all. So the other fingers, the mean extension lag is similar. So it doesn't seem like it prevents extension or progression in the adjacent fingers or causes it, surgery. Retreatments, so surgery not often, with the other almost 10% at 2 years. What about the untreated fingers? No difference. So what were the risk factors for progression? Older participants had less progression, so each year of age decreased progression by 0.4 degrees, meaning that 10 years older get 4 degrees less. And smoking increased progression from 3 months to 2 years by almost 6%. Retreatment, if you are treating fifth finger, you had a higher odds of receiving new treatment. So in conclusion, at 3 months, the outcomes are similar, but however, at 2 years, results were maintained better with surgery. No difference in adjacent fingers. And smoking, young age, fifth finger are risk factors for progression, so they might benefit most from surgery. Thank you.
Questions? One there.
Which basis was
Sorry.
on which basis was the recurrence definition based on the international definition or a specific finish?
I don't think we need those cutoffs at all because we can measure the progression as a continuous angle. So you don't weigh yourself whether you weigh more than 70 kilos or over 70 kilos if you can say that you weigh 77 kilos, right? So that's why we were using the progression as and then retreatments.
Are you measuring from the beginning of the operation or you wait 6 weeks and then start measuring?
The progression we measured baseline, 3 months and 2 years. And then we have the exact angle for all the time points.
What is the 0 point before you start the measurement?
That's just before the treatment.
It's the operation day or 6 weeks later?
Exactly, yes. Yes, it's the day of operation or day of needling or day of first collagenous injection.
You should be congratulated for this definition because that's the truth.
Thanks.
Another question down here.
The difference after 2 years was around 10 degrees. Do you think that's a clinically relevant difference between surgery and PNA?
Well, if we are looking at the results, so there was 10 degrees difference, which is something that we probably consider that it is not clinically relevant. But however, if you look at the success rate, and in the success rate and then global improvement, the patient or the participants could weigh in all the things they considered about the treatment, and they were happier after surgery compared to the needle. So I think it is relevant difference because they considered themselves being more often in success. But I don't think 10 degrees makes that large difference, so that was something that we weren't expecting.
Did you stratify between PIP and MCP?
Yes, we did. It's the same, basically the same results. So even PIP, we thought that we can't needle the PIPs as well, but there was no difference in the PIP joints after 3 months. And then at 2 years, there was this difference. So it doesn't look, that's not effect modifier. We were looking at that, but we are not probably powered to detect small effect modifying effects.
Any other questions? Great, thank you very much.